Good afternoon, my dear colleagues. It's my pleasure to be here today with you. Today, I want to get in depth in not very common orthodontic and surgical principle, which is, could orthodontics do grafting, do bone grafting? Actually, during my master's studies, I was lucky to be involved in many orthodontic and treating many adult orthodontic cases. What would you face with adult orthodontics? Mainly, you'll face extractions and periodontal problems. So we had a lot of question marks there. Which tooth is hopeless? Where is the bone level? Where is the periodontal ligament level? Would I'm going to extract these teeth or keep them closed space or open space? What about the oral hygiene and compliance of the patient at this age? So let me first talk about what happens after tooth extractions. Actually, we may get vertical bone loss, which is the height, the reduction of the height, and we may get horizontal bone loss, and end up with atrophic ridges like this or this, or like this. So we need first to know what happens after dental extraction. The Wisden et al. 2009 systematic review identified. Sorry. Okay, identified 12 randomized controlled trials explaining what happens directly after any dental extractions. We found that the buccolingual width of teeth decreased by 3.87 millimeter, about 4 millimeters. That's for the width, and the height decreased by 1.67 millimeter in height. So please remember that's classic forceps extraction. There is no alveolar fractures during this extraction, and this is normal healing within 6 months time only after extraction. So what do you think would happen after 1 year and 2 years of extraction? Okay, so alveolar bone atrophy occurs with classic forceps extractions, also with fractures during extraction with forceps or elevators. Mostly it happens buccal and crystal, surgical extractions. So we're discussing briefly the cause for dental atrophy, ridge atrophy. So we have mentioned that with normal extraction, we lose 4 millimeter of buccolingual width and 1.5 or 1.7 millimeters of height. With normal healing within 6 months after extraction. Also, fractures during extraction cause more alveolar bone loss, surgical extractions more and more, periodontal disease, especially aggressive periodontitis, extraoral traumas, congenitally missing teeth. You'll find the ridge in place is atrophy, and bony cleft, and non-hygienic fixed prostheses and ill-fitting dentures. All of these causes lead to alveolar bone atrophy. That's why 3 concepts have been evolved. First, atraumatic extraction. Second is socket preservation, and third is ridge augmentation. So, from the early beginning, we are trying to surgeons and companies are marketing now several instruments for doing atraumatic extractions to preserve the bone width and height, like physics forceps, like using endoscopically assessed root splitting for cutting the roots and getting it out without harming the socket, and periotomes and electric periotomes. And implantologists have several techniques now, so like socket shielding to maintain the alveolar socket. But again, if the implant is not inserted immediately, a degree of physiologic dimensional loss will occur over time. So they went for socket preservation, which is procedures to maintain the socket dimensions and decrease the alveolar bone loss immediately after tooth extraction. So they put scaffolds and membranes and immediate grafts at the socket directly after extractions to maintain its width. They showed degree of effectiveness in decreasing the alveolar dimension loss, but still grafts were the most effective. Adding membrane increased the effectiveness of the grafts, but again a degree of physiologic ridge reduction should happen. Finally, if you get your atrophic ridge, so the surgeons go for ridge augmentation, which are surgical procedures done to regain the resorbed alveolar dimensions. A lot of grafts are available, like autografts, allografts, Plus, and xenografts. Autografts are harvested from intraoral and extraoral donor sites. They do different techniques like onlay grafting, ridge splitting, and putting a graft inside, or distraction osteogenesis to distract the infrabony segments into new positions. They do sinus lifting for where sinus pneumatization is present. But sometimes we may end with failure of the graft, which is 19.5 to 12.5 to 12.7%. You have risk for failure. And you get a lot of limitations, like that it's technique sensitive, surgical interventions. Usually it's more than one surgery or two surgeries. Graft may be rejected, donor site may be die, graft may resorb, and also smoking is a major risk factor for failure of any graft. Sometimes you may end with this failure of the graft, crystal, block grafts, buccal graft. So why to graft bone once we can grow it? I'm here today to review with you the concept of orthodontic bone regeneration. Very briefly, we can go through the concept of orthodontic tooth movement, which when we apply orthodontic force to a tooth, an area of compression and the area of tension occurs lateral to within the periodontal ligament, and the osteoclasts work on the compression side, and osteoclasts deposit new bone on the tension side, which leads to orthodontic tooth movement. But there is debate between orthodontists. I can remember during my master's training, do we move teeth with the bone or through the bone? I can remember when I get an atrophic ridge, my supervisor would tell me, no, don't move these tooth here, because there is no bone to move the teeth in. But actually, very interesting study, which was done at 1993, which was experimental on dogs. which was split mouth technique, by the way, where they have extracted fourth premolar. The dogs have 4 premolars. Extract four premolars and the fourth premolar and make surgical bone reduction up to half the level of the root of the adjacent premolar, so 4 to 5 millimeter of in height defect. And they distalize the third premolar for 6 months. Remember that we have 5 millimeter defect. They get no change in cement enamel junction to soft tissue, no change in probing depths. 1.1 millimeter vertical alveolar bone defect. The 5 millimeter defect became 1.1 defect. So we had nearly 3 to 4 millimeters generated. So I think that we move teeth with the bone, not through the bone. Okay, so how could we as orthodontics help? It depends. If it's before extraction, we can help preserve the ridge. After extraction, we will see if we can regenerate the ridge or not. So first of all, before extraction. Before extraction, we can do orthodontic socket preservation, which is called also forced orthodontic eruption or orthodontic implant site development. It's mainly an extrusive tooth movement in the vertical dimension. When we apply a vertical force, the tooth extrude and new bone forms extrusion. Again, we extrude more new bone form. And again, until we have minimal defects, and then we will extract the teeth atraumatically with the new bone formed at the socket site without any augmentation or surgical augmentation or using grafts. So when it's indicated in teeth with periodontal affection, teeth with hopeless like internal resorption or external root resorption, fractured teeth or teeth with severe mobility. But also we have contraindications, which is the absolute contraindication for implants also, having an active periodontal disease, having a preapical pulsosis. If its tooth is ankylosed, so we cannot extrude it. If we have systemic condition that inhibits the bone formation like uncontrolled diabetes mellitus. So briefly, we'll review a few cases where forced orthodontic eruption or extraction was used. These teeth, the lateral, have grade 2 mobility and 5 millimeter probing depths. So using bends and piggybacks, the tooth was extruded, and the crown was cut. Now the post is inserted into the root, and here we can see that at the radiograph, the last one, we can see the amount of alveolar bone generated. So you can easily go and put your implant without any need for any graft. This is the final result with healthy periodontium and biologic periodontium, by the way, biologic bone and biologic PDL. Class 3 mobility for the anterior teeth, grade 3 mobility, severe horizontal and vertical bone loss. So the treatment plan was to extract the lateral incisors and put an implants on the lateral sides and extrude also the centers, but not to extract, to use as abutments. And here we can notice the extrusion, the amount of extrusion happened. Implants in place, provisional restoration. You can notice the amount of bone around the implants. This case, this beautiful crown of the left center incisor has an external resorption, which was untreatable. Treatment was to extract it orthodontically and put an implant support prosthesis. Then you can put the implant and end with good bone level and good periodontal margin without any metal display, without any violation of the bony socket. This case has severely periodontally affected anterior segments, grade 3 mobility of the upper right lateral, and grade 2 mobility of the rest of the anterior teeth. The orthodontic decision, the treatment decision was to extract only the upper right lateral, which was the most affected. Orthodontic intrusion of the upper right central, upper left central, and the upper left lateral, and put an implant, of course, at the right lateral. So, with extrusion of the center of the lateral and the intrusion of the central, we can notice the amount of bone generated at this site. Check the effect that's distal to the lateral at the pre-treatment, and now this is the amount of bone, and here's the implant in place. So I think that we can preserve the sockets in such cases. Lastly, 62-year-old man with vertical bone resorption around the buccal segment from the 5 to 7 and 7 millimeter probing depths, and the grade 3 mobility and electric pain on air and cold and hot, which indicates root exposure. The treatment was to extract them, but extracting them without orthodontics, without bone regeneration, would leave a very large defect at the whole buccal segment. So the decision was to orthodontically extract them. Away from the orthodontic technique used, again, teeth are extruded, new bone heights are established, and implants are in place. Sorry, again. And here it is at the end. So do we have an evidence to do that? There's a Koraim et al. 2008 systematic review, which was a systematic review of case reports, which is not very high level of evidence, but it is available right now. 19 studies were identified. They found that the most common cause for forced orthodontic extraction was severe periodontally affected. And they found that it was successful and viable option to increase the bone and gingival support at the affected sites. In all the 19 studies, no additional hard or soft tissue augmentation was needed in all cases. No comparison. Actually, we don't have comparisons to surgical techniques until now, but it is an effective technique. So, what would we gain from forced orthodontic extraction? Is leveling of the infrabony defects, gaining new bone height, clinical crown lengthening, gingival margin repositioning, and avoiding the radical lapse after extraction, avoiding crystal and bone loss during forceps and elevator extraction, increase the amount of attached gingiva, and improve the recipient implant site. But what's the disadvantages? It's a longer treatment, and we would rely on patient cooperation like any orthodontic treatment. But wait, remember that we will end with biologic, no surgery, and no graft failure risk. So again, how could we help? Now we know if you don't extract the tooth, we can preserve your socket. But if you have already extracted it a long time ago and you get an alveolar bone loss, we may regenerate it or augment it orthodontically, or not. Very interesting trial was made by Dentistry et al. 1996. They got 32 second premolars in free end saddle cases where 6 and 7 were extracted. It's nothing to do with the implant at this case, but there is a very important information. So, and they distalized the second premolar by mean average of 9.4 millimeters. And then what happened? That's what they got. New bone is nearly of the same height and width formed at mesial to the second premolar. So new edentulous ridge between the premolars was formed with nearly the same height and width. Around the second premolars, they get only from 0.2 to 0.5 vertical bone loss. 0.2 on the mesial sides and 0.5 on the distal side. No mobility, no change in probing depths, but unfortunately, 14.6% have 0.7 lateral root resorption, which luckily was 50% repaired after 1 year later, and no subject lost the vitality over 9.6 years of follow-up. So the lateral bone resorption doesn't affect that much, sorry. Another study was made at 2011, where 10 teeth were moved in 10 edentulous spaces. Also the probing depths, on the edentulous side was 0.6 millimeter increase. On the tension side, they decreased by 0.4 millimeter. The bone height increased by 0.6. On the tension side, they decreased by 0.4. So the bone level remained the same before the same as orthodontic tooth before orthodontic tooth movement. They get, according to Malmegra 1983 classification of root resorption, they get apical resorption at stage 1 to 2, which is acceptable. 3 also is acceptable, but they didn't get it. Lateral root resorption of 1.4 millimeter depth, which was corrected by 50% also after 1 year. This one of the results. What about the bone depth? What about the bone depth at the new edentulous site? They moved this the second premolar, this premolar distally, and they get new edentulous, which is 1 millimeter from the original decrease. That's mean that at this site there was if this was 10 millimeters before the orthodontic tooth movement, now it's 9 millimeters, which I think that's fairly enough for implant placement. And on the atrophic side, they get 1.6 millimeter increase of bone width. So what do you expect if you move the teeth? This is the average mean buccolingual width of the sides. If you have any atrophic side of these, you can move the adjacent tooth and get only 0.9 millimeter decrease, which is like that. So you can generate 6 millimeter buccolingual widths on the lateral and canine sides, 10 millimeters buccolingual widths on the premolars, and also. So what implantologists are looking for? They are looking for mesiodistal widths, buccolingual widths, and height, and bone height. For the mesiodistal widths, I think that we are the masters. We have no problem with that. They always refer case for us to do it. If they got a congenitally missing lateral and the central and canine took the place, so we can easily move it mesiodistally and open space for their implants. But what about the widths, the buccolingual widths? Actually, for the best aesthetic results, they think that they need 2 to 4 millimeters on each side. So, if you got an atrophic ridge, you can move the adjacent tooth and and you will get. If it was 10 millimeter, you will get at the new edentulous site, you will get 9 to 8 millimeter bone width, and you can put your implant at the new edentulous ridge. What about the crystal bone height? They need 2 to 3 millimeter of bone from cement to enamel junction, like that. So again, if you have an atrophic ridge, by moving the adjacent tooth, you are creating a new bone on the site which the tooth have moved from, where you can put your implant. There's few cases here. You can see at this case, severe vertical bone loss at free end saddle case. You can check after distalization of the second premolar, you can check the height of the bone, which is nearly at the cemento-enamel junction. But unlikely, at this case, they have prosthesis, not implant. But you can still have information about the alveolar bone height. Again, severe loss, vertical and horizontal bone loss. You can distalize the second premolar and put the implant between them. You can notice here the amount of lateral root resorption. So my advice to orthodontics is to keep the levels, the force level as low as possible. But you can notice from the pre-treatment to the post-treatment radiographs, the amount of bone generated into the new edentulous side and likely around the second premolar. For this case, again, severe width loss. So the height and width. So the decision was to distalize the second premolar at this and in the extracted molar space. And check the quality of the bone they have now. Look at the continuity of the alveolar bone after tooth movement. So bone generated around the tooth into the atrophic site and into the new edentulous site. This is the buccolingual width of the bone you can get. And you can easily put the implant without any grafts into the new biologic bone. So what's the protocol for this procedure? Actually, there is no settled protocol or guideline for the horizontal orthodontic alveolar augmentation or regeneration procedure until now. But depending on the review of the current literature, the following protocol can be suggested. So we can change this protocol to recommended protocol. If you got first molar site, where the first molar is extracted, you can easily mesialize the second molar and put an implant at the second molar site. If you got free end saddle, where 6 and 7 are extracted, you can distalize the 5 and get an implant between the premolars. What about the premolar side? If the 4 is extracted, you can easily mesialize the 5. They look the same, nearly the same. And if you have 5, you would distalize the 4. For the canine, which is rarely could be referred for this procedure because of the firm alveolar socket around it. But if you have an extracted 3, you would mesialize the 4 and go for premolar substitution and put an implant at the site of the premolar. And how to do this substitution? Easily, you need to extrude it a little bit and put some buccal root torque. You may, in some cases, you may need some restorative treatment for the color and shape of the premolar. So most of the cases, it would work without restorative because both are yellowish a little bit in color. For the lateral incisor, because of the long roots of the canines and minimal mesiodistal width of the lateral, you can get the canine, you can mesialize it and get it back to its original position. So you would generate a bone at the lateral position and put your implant. For central incisor, which is really interesting, you cannot move the lateral because it's because of the difference of the mesiodistal widths, but you can easily move the contralateral incisor across the midline, do some stripping IPR for the distal margin of the central incisor, and put the implant at the original position. Finally, for the low mandibular central incisor, you got two options. You can move the contralateral central, or you can move the lateral and do some stripping to mimic the central shape. Finally, for the lateral, you would distalize the central incisor and put the implant at the central position. So I would recommend that we may encourage our implant colleagues to refer this case to us to get a biologic and healthy periodontium and bone with less risk of graft failures and aesthetic consequence on the long term. But we need to always remember these cases, before treatment initiation, we have to ensure that any active periodontal disease must be recessed before the treatment. Anteroposterior and vertical anchorage preparation is critical in these cases we need the right tooth the correct tooth to move, not all the adjacent teeth. Orthodontic force must be kept at suboptimal level. Again, suboptimal level, not even the optimal level, because moving the teeth into atrophic cortical plates would be harmful for the roots, so we need to do it very gently. Root resorption must be monitored throughout the treatment, and segmented arch mechanics are preferred as long as practically possible. That's all for today. Any questions?